Today we have with us for our Community Grand Rounds session, Dr. Nwamaka Eneanya, who is an attending nephrologist and assistant professor of medicine and epidemiology at the University of Pennsylvania. She is also director of health equity, anti-racism, and community engagement in the nephrology division. Dr. Eneanya holds an undergraduate degree from Cornell University, medical degree from Meharry College, that's my father's alma mater, and a master's degree in public health from the Harvard T.H. Chan School of Public Health. She completed her residency in internal medicine at Brigham and Women's Hospital and nephrology training at the Combined Nephrology Program at Massachusetts General Hospital, Brigham and Women's Hospital. She is a clinical investigator with numerous research interests at Center on Palliative Care, Informed Decision-Making, and Health Equity among patients with chronic kidney disease. In 2020, she was recognized as a under 40 leader in minority health at the National Minority Quality Forum. Welcome, Dr. Eneanya.
Thank you so much for having me, Dr. Taubman, in that wonderful introduction.
So I'll start with a question about the origins of your interest in the research that you've been doing the last few years. But what precipitated your interest in research on race and algorithms?
Yeah, that's a great question. And I think I have a unique background that has brought me to this place. I really feel like it's my divine calling to do this work. And so normally when I give talks, I start with the financial disclosures. But then, I also give some life disclosures for people to really understand why I'm doing this. So the first life disclosure is that I am an African-American nephrologist, one of few in the country. And I have a great passion for treating patients who are underserved and who are minoritized in this country. The second is that I studied Black sociology at Cornell University. I actually did my honors thesis about racial segregation among Black students on campus when I was there. And so this has been kind of ingrained in my thinking since I was a teenager, this interest of looking at race relations and really understanding the sociology of that in my career. The next disclosure, as you already mentioned, was attending Meharry Medical College for my medical training, which, if people don't know, it's a historically Black medical college and university. It was actually the first HBCU medical school in the South to train physicians who were denied entry into other medical schools. So really being trained to serve the underserved, which is the mission of Meharry Medical College, again, kind of builds upon my collegiate training. The next life disclosure is that I'm Nigerian American. And so people have talked about ancestry and what does that mean, coming from West Africa, being born in the United States, what does that mean for me? It means that I have kidney disease in my family. And it's affected my family members significantly. I've also been tested. I've been genotyped for a particular gene, APOL1, that has been shown to be associated with a high risk of development of kidney disease, but also the progression into kidney failure that requires dialysis. So I have that information personally about myself. So when people talk about ancestry this and, replacing race with Black race with African ancestry, that doesn't really add up in my mind, given that knowledge. And so that brings me to this place here of being a health equity researcher and being a nephrologist and treating hundreds and thousands of Black patients, managing their kidney disease. All of these things have brought me to this place of why I have to speak out about injustices that I see in science and clinical practice, and why I do have that special type of training to be able to say confidently why things are wrong or how we should change things.
Thank you so much for that explanation.
Sure.
Can you talk a little bit about some of your major research findings, things that stick out in your mind?
Yeah, sure. So my research portfolio really started with looking at treatment decision making for patients with advanced chronic kidney disease, and really focusing again on, as you mentioned, palliative care and end of life care. And that stemmed from my experiences training and seeing at the end of life, in particular in the ICU, very different care that was being received among Black patients with kidney disease, classically on dialysis, versus other racial groups with kidney disease and on dialysis. And it struck me that Black patients and their families were very unprepared for these final days in the hospital. And they typically received more aggressive care in the ICU compared to other families. Now, this has been described quite broadly for all disciplines of medicine, not just nephrology. And I wanted to kind of investigate that further. And so my work brought me more upstream outside of the kind of critical care ICU space to just outpatient nephrology care and speaking to Black patients with chronic kidney disease that had not yet advanced to the point of needing dialysis, and just really, garnering their perspectives about treatments that they desired if they became critically ill, and comparing that to those of people who are identified as white. And what I found in that early work, I started this work as a renal fellow, is that Black patients, first of all, their health literacy was on average lower than white patients with kidney disease, and that their understanding of kind of what that care meant at the end of life, including resources such as hospice, was very poor. And it's really unclear why. Could it be a health literacy thing? Could it be a communication piece between clinicians and their patients? What did that look like is still evolving for me, but it was clear that starting at that place perhaps could predict why Black patients with kidney disease were receiving such intense end-of-life care. And just to let you know, when you poll the American public, most people do not want to have a medicalized death. Most people do not want to die in an ICU. It's scary. That decision-making is intense. And so why is it that Black patients and even other patients of color, Hispanic patients, and there's also some literature about Native American patients, why do they keep receiving that care? And I think a lot of people are interested in looking at that, but that was a lot of my work had come down to that. And so my current work has focused on intervening, developing tools to educate patients early on in their disease process, and also bring in their families, bring in their caregivers. Let's have these discussions when you're not as sick, when you can think lucidly about the care that you would want, and document that care and have it be a continuous conversation. That has been a focus, a large focus on my work, is improving the quality, not only the quality of life of patients with kidney disease, but also the quality of death, and bringing health equity into that care. That's one piece of my work. The next piece would be how we use race to diagnose and manage kidney disease. And that is something that's become more recent in my work. But as I stated before, I kind of always challenged this notion of using Black race specifically to diagnose and manage kidney disease. I actually never used it as a trainee and as an attending. And then we wrote about it in 2019 in JAMA, myself and colleagues at the University of Pennsylvania. And that prompted kind of this national discussion of what are we doing and how did we get here? And my work has shown that, kind of othering Black people, making them different in some way biologically, and then using that to guide their clinical care is not right. If we're not being transparent, it doesn't really make any sense. We know that, for instance, genetically, that we are more similar in between racial groups than we are within. And so why would we treat people of the same race they're biologically different than other racial groups. And again, it places Black individuals at a disadvantage if you're, for instance, using Black race to adjust their kidney function, which assigns Black people better kidney function. That means that they are seen as less sick. And we know that kidney disease, in particular kidney failure, disproportionately affects Black patients. And so we're kind of making them appear, assigning them better kidney function, which means that they are less likely or they'll receive nephrology specialty care later in the disease course. And we know that there's huge benefits for having someone like me intervene early on into the disease process. There's mortality benefits. There's decision-making benefits. And then also kidney transplantation. That's a huge box. We know that Black individuals are less likely to be listed for kidney transplant for a variety of reasons, but we're assigning them better kidney function, which means that their evaluation processes, again, are delayed as well. And we'd like to promote kidney transplant preemptively before somebody starts dialysis. You tend to do better. Your mortality is better. You skip that whole process. And so, challenging that status quo has been something that I've been very passionate about. Again, giving my life disclosures and my expertise in this space, that it's wrong. And I'm proud to say that there should be a large announcement coming soon about that practice. We've already had our two largest societies, American Society of Nephrology and the National Kidney Foundation, come out in the spring to say that we will no longer do this. And we're just awaiting the details of what that looks like. And that announcement is forthcoming.
That's huge. In fact, as I was listening to the question in my head was, how have your professional associations and peers in the field received this different way of looking at, kind of care for African American or Black patients? And so it sounds as though it's been well received.
I think there's been support from many. I will say that, in particular, the leadership at both of our societies and the American Society of Nephrology and the National Kidney Foundation has been profound. And I'm deeply grateful for that. And there's been a lot of support, I will also say, from other leaders in the field, but also medical students. I mean, I've just been so inspired by medical students that refuse to use this tool. And I really credit them. There was actually a small group of medical students at Beth Israel Deaconess who, they attended Harvard Medical School, that actually, they were the first to get rid of this practice even before I wrote about it. They really kind of sparked this dialogue, and they refused to be told by whoever was teaching them in that class, like, this is how we do it. This is just how you should do it. They were like, no, this is wrong. And I think that has really contributed to pushing the field to do better, because this is the future generation of clinicians and scientists that are not accepting this practice. And so I would say that's where the support has been. There's also been quite a bit of resistance. And people who have kind of made it their point to push a narrative that stopping this practice will be harmful for Black individuals because the science doesn't support stopping this practice, which, I understand we need science. I'm a scientist myself. But, asking to prove that something is, inequitable or racist is very hard. It's very, very hard to do. It's hard to publish it. It's hard to get funding for it. And so to kind of wait for, clinical trials to prove that something that sociological scholars, Dr. E.B. Du Bois did the first sociological experiment in 1899, looking at Black individuals living in Philadelphia and looking at social inequalities and how that dictated health inequalities, not essential biological differences. We have that information. We've had people build upon that for centuries. And so to say that we need new science is a little, it's been tricky. However, like I said, there are people that are very invested in doing that type of science to make sure that we continue to push forward. And I'm incredibly grateful for that.
That is an incredible lesson learned, because those of us who are in this work are always pushing boundaries and challenging conventional wisdom and traditional ways of doing. And I'm really grateful for the work that you're doing, and the students that you're working with are very fortunate to have somebody like you to provide guidance in this space.
Thank you.
So this, you may have addressed this question in your previous or touched on it, but what are the health equity implications for clinical practice? Like, what are the implications for cost of care? It's pretty clear what the implications are for the quality of care, but for healthcare systems that are trying to evolve their models from fee-based to value-oriented care, what are the implications for this different way of diagnosing and treating Black patients with kidney disorders?
Yeah, I mean, I think, what I've read and what I've seen, especially from a lot of these value-based startup companies that are focused on this type of care, not necessarily just for kidney disease, but just primary care in general, is that you have to move upstream, and we have to incorporate the factors that we know are a direct impact of structural racism. So we know that structural racism is a system that is built upon inequality, that is based on phenotypic appearance, that unfairly advantages individuals and also unfairly disadvantages individuals. And so this is why we have differences in social determinants of health, right? We have education, income inequalities, neighborhood segregation, all of these things that lead to poor health outcomes. And what we really need to do is to be mindful of these things early on in the disease process and then continue as we manage. And so, the fact that there are systems that don't incorporate social work in the management of chronic kidney disease is striking to me. I understand it's another, line item on cost, right? Social workers cannot bill, but the value is incredibly important because, first of all, you're taking that the expertise in social work that clinicians kind of have to bear when you don't have a social worker, you're taking that away. So I can actually focus on the things that I'm trained to do. I am not a social worker. So when I have a patient who comes and they say that, I can't afford nutritious foods, here I am chasing your hyperkalemia. You're getting admitted, you're getting dialysis, right, to treat this high potassium level, when really what we really needed to do was have someone intervene, such as a social worker. We are doing, for instance, a pilot where we'll have, we'll screen for food insecurity among the kidney disease patients in our clinics, and partner with food pantries and have helper shoppers go with the patients to those food pantries where they can select and learn about foods that are nutritious and healthy for them. Now, that kind of care to me is the epitome of centering health equity, and thinking about food insecurity, which is not taught in medical school, by the way. When we do those interviews, it's not how do you afford your food, how do you afford your medications, it's are you taking them? And that's wrong. And so I think like having that's just an example of having that mindset, which yes, in the beginning, you may have a line item. This may be costly in the beginning, but down the road, it pays dividends in terms of preventing, for instance, admissions that are related to the sequelae of not being able to afford a nutritious food or not being able to afford your blood pressure medication or any other medication that's pertinent to your CKD care.
Yeah. Who are the helper shoppers and how are they trained?
Yeah, so it's really interesting. We have nursing students and nutrition graduate students who are just so thrilled to be doing this type of work. We've thought about incorporating medical students. It's a small pilot that we're doing and we need to scale up, but it's going to be a 6-week program where, weekly they'll be going with the patients, again, to food pantries that are local. So they don't have to travel far, that have the foods there that they can select and learn about the quantity, the qualities, different recipes that they can do that are safe for their kidney disease. So those are the shoppers. And thinking about how to scale up is going to be the next part of this project after the pilot, we complete the pilot.
That's really interesting. And the other question that I had while listening to you is, the way we're thinking about these kind of social interventions, there are, basically interventions to address those, urgent social needs. People need to eat today. Are you thinking at all about addressing the drivers of those needs, for instance, like those community level determinants and the structural forces that actually lead to the creation of those social needs? Is that part of your work at all right now?
It's not a part of my research work at the moment, but it is of great interest to me because I think that is where the key is. Even my interventions about educating patients about their treatments and, making sure advanced care planning and all of these things happen early before they get critically ill is a little too late. I think, starting as early as possible. And again, thinking about community level interventions that where you're innovative about your care coordination, your social work, your caregiver support. I mean, there's so much there that can be done, that can be integrated into healthcare. Right. That wouldn't, in my mind, be too hard to do, right? Finding community partners. There's always people that are interested in doing this. I mean, they jump at the opportunity once you bring that idea to the table. And that is also key, is keeping those community partners central to this process, because we think we know, right? Coming from the inside. And even me, sometimes I'm struck when I'm listening, I'm like, oh, I didn't even think about that. That's because I'm not in the community working with food pantries every day. That's not a skill set that I have developed. And so bringing those partners of people who are like, oh, actually the food pantries are actually open on Mondays and Fridays. So we need to think about that gap in between and how we're going to incorporate that into the patient's work schedule. I didn't know that. So
right. Okay, great. Thank you. Mm-hmm. What gives you concern or pause for the future of research in this space where you're working?
The concern, again, is this tension of, merging. There's some people that feel like public health has no space in medical care. And I don't get that. Again, that's just not been the way that I have thought about things my entire life. And I think there's a huge resistance to keeping them separate and to even keeping, for instance, the sociological scholars, or anthropological scholars separate from clinical care. But how is that possible, right? We know that there's so many social aspects of society that affect health outcomes. And so it gives me concern that there's this kind of this elitist kind of mindset of that, like the biomedical scientists are at the top of the totem pole. We know everything and everybody else is kind of anecdotal. Like, that's insulting to call a scientist, a sociological scientist, anecdotal. Like, people who've written books and actually did research on this. And I think that is what gives me pause. We need to stop doing that. And I think this example of EGFR and kind of bringing in the sociological theories that we know, again, have been studied for a very long time into this space has been incredibly powerful. People like Dorothy Roberts, who's written about this in multiple books, by the way, who I'm lucky to have with me at Penn, has been phenomenal. She has just been such a force. And I think that we need to practice that going forward. We need to invite other disciplines who have focused on inequalities and how that can affect health inequalities. Let's bring them to the table. Let's stop siloing them. I think that's not good science, in my opinion, at all. And so that gives me concern, is that there's this resistance of like, no, we're going to figure out precision medicine on our own and we know how to do things and you don't. I don't think that that's right. I think that we should invite scholars such as Dorothy Roberts, and I know she's been getting requests left and right her whole life, but invite her to the medical schools, invite her to public health. Let's merge the two. Let's have collaborative grants, right? Where you need people from different disciplines to actually be able to apply for those grants and to do science better, so we don't end up having unintended consequences down the road because we've been kind of having this narrow-minded view of what biomedical science should be.
It's so affirming to hear you say that. I'm a social scientist. I'm trained as an urban planner. And, I worked with mental health professionals before this role, invited Dorothy Roberts to talk to clinical psychologists about their work to help them round out their understanding of what drives emotional health and well-being. And you're right that those of us who are, trained in the social sciences, I think there's beginning to be an appreciation for what we can bring to the table, hence my role at the healthcare system. But I can't agree with you more that we need to be more open and be willing and actually exercise some level of humility and appreciate what others can bring to the conversation and the solutions.
Absolutely.
And then what gives you hope for the future in your space?
What gives me hope is the kind of the racial reckoning that is occurring, and the passion that I'm seeing in particular from the younger generations. The undergrad, I can't even start with medical. Undergraduate students have now been reaching out to me, wanting to do projects, so invested in this. Curriculums are changing, right? So people are getting taught earlier on, whether it be public health or medical science or whatever, scientific program. Statistically, people are talking about the epidemiology of health equity. Let's stop just putting race in the regression analysis, right? Let's think critically about what we're actually controlling for. What does that mean? How will we interpret those results once we see them? Like, it starts from the ground level when we're planning a research, when we're designing research. So that gives me hope, is that curriculums are changing. There's passion to do this better. I think there is always going to be a group of people that are resistant, but I do think that they will become the minority soon, and that this new generation will kind of uplift the science that we're seeing this being published now quite frequently, to push for real change. No more describing. I think a lot of work that we've seen up until this point of health equity has really focused in the medical sciences, is really focused on like describing and just, documenting. That's great. We need that type of science, but the next step is the action. And that is what I'm hearing from the younger generations or some of my contemporary colleagues that are like, wow, I never knew this. But now I want to do this. I want to apply my expertise of, AI, for instance, in health equity. I think a lot of that as well. And that is, to me, that is the most inspiring piece. Like, this is awesome. That everybody now wants to work on this. And it should be. Health equity should be pervasive in everything that we do, until we no longer need to talk about it.
Right, exactly. It's interesting you talked about the curriculum, and I'm thinking of the residency programs and, ACGME and the recommendations and requirements. My experience has been that those requirements make it really difficult to integrate real health equity work into the training of medical residents. Have you seen otherwise ways in which meaningful health equity work could be integrated into that curriculum so that physicians in training get some substantive exposure to this space?
I haven't. So I'm not, really very close to the ACGME kind of curriculums at Penn. But I will say, in my discussions with some of my colleagues and scholars who are interested in this, there's great interest. So right now, I think it's limited to just bringing in different lectures that have that content and giving a noon type of lecture, talking about cases and things like that. But I've also spoken to people who are very interested in kind of doing more. So as of now, for instance, we have in residency, we have something called mortality and morbidity conferences, M&M conferences, where you'll review a case that didn't go so well, right? And rather than to be kind of pejorative or to discipline someone, it's anonymous. You just learn lessons learned, how we could have done this better. I've heard people, for instance, talk about doing health equity rounds where, someone can talk about discrimination that was actually, that actually occurred with the patient, and deconstruct what happened to that patient, right? When racial discrimination occurs, or deconstruct what happens when we're not thinking about the effects of structural racism, what happened to that patient's care, and really bringing those lessons in to residency training, I think will be incredibly powerful. Again, not to blame anyone, not to finger point, but to really check your bias at the door. Like, oh, wow, this case, I was the resident on this case. Okay, let me straighten up and listen to how things could have been better. I think that is very promising. Think innovative curriculums or education programs like that.
Thank you. And is there anything else you would like to leave? Any other thoughts you'd like to leave to the people who watch this piece that you'd like to share?
I would just say that, keep going. For those who are inspired to bring change, you have the power to do that. Again, I talked about the research where I have funding. And that is, a little bit of a pivot from what I'm doing now. And once I felt that call that I have to speak out, I think everyone should follow that. Everyone has a unique story, a unique set of skills and expertise that they can bring to the table to push for change. And I say, go with that, right? Especially when it comes to health equity. If you have this kind of drive and it's, you feel like you have to do something, I say, absolutely do it. That is how we've gotten to the point of challenging, this race in EGFR and using Black race to diagnose and manage kidney disease. It is because people are like, I refuse to accept this. This is wrong. And I should say and do something about it. I say, go with that.
Thank you so much, Dr. Nwamaka Eneanya. Thank you so much for spending time with us. I'm going to enjoy listening to your words again. There was so much information you provided, and thank you for your time. I appreciate it.
Thank you for having me again.
Thank you.